So I was hoping to switch gears a little bit in terms of, as all of you were talking, in terms of demonstrating outcomes. Have any of you thought about trying to get connected to Medicare claims data to see what the long term? Because I don't think necessarily really significant results like in 6 months, clinically significant. They might be small gains, but maybe over 2 years or 7 years, you might see divergences between the groups that participate in these and the other kinds of interventions we're going to hear about later on in terms of time to placement in assisted living. That won't help you with Medicare claims, but times to entering a skilled nursing facility, an assisted living facility, using home health, maybe increased use of or decreased use of hospitals, that sort of thing. If you thought about doing that, or what might be some of the obstacles or that sort of thing?
We actually are thinking about doing that with, as part of the new NIA-funded grant that Dr. Terry has just gotten. The co-investigator who we're going to have working with us is a specialist in looking at cost effectiveness, and that's something that he suggested and has experience with doing, which we never have. So that's kind of on our horizon and agenda for that grant. The other place that it's of interest to us is, again, as we dialogue with Group Health Cooperative. They have a large computerized database with lots of service utilization data, and there would be potential in that system to also look at those kind of data, but we haven't so far.
Have any of you, with these three interventions, systematically looked to see if there are people with certain characteristics who aren't helped as much by the intervention as other people? It gets a little bit at Lisa's question about retention, but that's kind of one of the more extreme forms, maybe, of not being helped. A little less extreme might be people who just don't benefit as much as other people. Have you looked at that?
Yes. We actually didn't look at that on purpose, but it came out in the data. For Memory Club, people who are more impaired, with people with dementia who are more impaired, don't get as much out of the intervention as people who are less impaired. So we did find that. And certainly for Meetup, I think there's some self-selection going on, because we can't randomize always. So it's a little bit hard to find this unless you have a randomized control trial. But for Meetup, clearly people self-select out who aren't interested in or who are socially afraid or don't want to have social relationships as much. But for Memory Club, we accidentally sort of found that, I guess there are no accidents, but we did find that people who are more cognitively intact benefit more from that type of intervention than people who are more progressed.
And it's a very small N of 2, but people with frontal temporal lobe dementias have a much more difficult time attending and engaging socially, and those are the people, that subgroup is the group that we've had the most difficulty working with over time.
In RDAD, a lot of the exclusion criteria are going to be related to physical disability. So, of course, we're not recommending that people be enrolled if they have had a stroke syndrome or Parkinson's disease that's affecting their ability to walk, their mobility ability. If people aren't able to walk across the room because they're too frail. If they are blind or deaf and are unable to kind of listen to the instructions that are being given to them, how to follow through the exercise programs. In terms of the behavioral management side of things, our experience with studies is it's not easy to figure out who doesn't benefit. It seems like if you have a caregiving situation which is already in crisis, sometimes the caregivers are coming to you wanting to be part of a program in the hope that your program is going to be the magic bullet. And when it's clear after the first couple of sessions that this is a process and the crisis can't be resolved immediately, then they're going to place. So I think that's one thing to look at is, how stable the home situation is prior to enrollment. We did find in the randomized trial with RDAD that individuals who came into the study with higher levels of depression were more likely to show benefit, at least in terms of mood improvement, which of course you would expect because their baseline's starting higher. But I think there's a lot of qualities about the program that would lend itself to being something that would improve mood. So those are the kinds of things that we're looking at.
I agree with that, and I think that to get to your question, David, the two that we exclude for so many things that we know don't work from trying things in the past, like for Memory Club, if someone's coming in a crisis situation, they're not going to do well in Memory Club. If someone is having some sort of extreme mental illness or couple dynamic that isn't going to play well in a group, they need individual counseling first. We exclude them. If people have frontotemporal dementia, we exclude them. So, I mean, we're sort of excluding out a lot of folks who we know from past experience just don't do well. So it's not coming out in our outcomes. Or if they're blind or deaf, because they can't participate and talk. If you can't hear, right? So we exclude all that.
So I have one more quick question, and it relates to people with dementia that live alone. I'm wondering if you've had experience in your program in working with people with dementia who live alone, and how that's a different experience than those that might have a caregiver, for example, that's actively involved.
About 50% of our participants do live alone, and it's mostly just infrastructure support. We have a great transportation system, which a lot of communities don't, so we arrange transportation for people. If they can't pay for their transportation, we find funding to support that, and that's just an added consideration. How do you get the person to a program if they live alone and they're no longer driving? We do have a few people who are early enough that they still drive themselves there. And if we're worried about follow-up on a certain issue, we usually just make sure that we have a family member that we know is involved with the person enough that we can contact them to follow up with any concerns. Or if we really want somebody to work harder on something at home, then we'll follow up with we take the initiative. And so I guess it involves taking more initiative to connect with families, and then also making sure we have the infrastructure to support getting that person to our program and home safely, and that's an additional care consideration.
We also have people who live alone that come to programs. We really promote having someone else come to the program with you for Memory Club. I mean, it's a dyadic intervention, and so we encourage people. We encourage people to bring. It doesn't have to be a family member, but I think being alone in this is not a success predictor. And so part of our job, I think, is in many of these programs is to get people socially networked and connected, regardless of whether they live alone or not. But it's especially important if someone's living alone. And so, I think part of the stuff that we do with folks with early dementia who are living alone is help them to develop a supportive, connected network that they're going to need over time. So I think that the power of that can't be underestimated.
And RDAD is, of course, a caregiver-mediated exercise program. So we started out with a randomized trial requiring that the caregivers live with the care recipients. And part of one of those small H's I was talking about, the small H hurdles, is what kind of requirement for a caregiver involvement do you allow as you translate this out to the community? So we're no longer saying a caregiver has to live with the care recipient. The caregiver does, however, have to be able and willing to come, at least on a daily basis, to help participate in the exercises. And so there has to be an involved caregiver of some sort. And we typically recommend, again, would be one of those things, what would be an exclusion? We typically recommend ideally there be an identified caregiver, not just for purposes of reporting, but because our experience clinically has been when you have a situation where caregivers are sharing the responsibility, things tend to start falling through the cracks. Someone's going to be there one time and then they don't make it, and the person wasn't going to be there on Tuesday, but they have to come and they don't. So it just gets more complicated the more players you have involved. Similarly with paid caregivers, sometimes a paid caregiver is great and sometimes a paid caregiver is not so great, even though the family thinks they're great for supervising care. They may not be great in participating in this kind of an exercise program. So there's a lot to think about in terms of taking in caregivers. But
my name is Greg Case, and I'm also with the U.S. Administration on Aging of the Administration for Community Living as the Director of the Office of Supportive and Caregiver Services. So our panel today is, and I suppose I need to say, non-drug treatment modalities for family caregivers. Although I have to say, as the caregiver of my father, who is mid-stages Alzheimer's, sometimes our family interactions with him and the staff at his memory care facility feel like interventions, I have to say. There's been more than once when that's the case. So at any rate, we're going to be focused. Last session was focused primarily on individuals with dementia, and these interventions are primarily focused on the family caregivers. So let me introduce our panel. This session will run much like or exactly like the last one did. Each person will have a chance to speak for approximately 5 or so minutes. Then we will have a facilitated discussion, after which there'll be an opportunity for comment and discussion with all of you out there in the audience. So our first speaker today will be Dr. Laura Gitlin. As many of you know, she's professor in the Department of Health Systems and Outcomes with joint appointments in the Department of Psychiatry and the Division of Geriatrics and Gerontology in the School of Medicine. Dr. Gitlin is going to be introducing the Skills to Care model, which is a Reach One environmental skills building program. Following her, Dr. Mary Middleman, who is the director of the Psychosocial Research and Support Program of the NYU Comprehensive Center on Brain, Aging, and Research, and professor in the NYU Langone Medical Center, Department of Psychiatry. And of course, she's going to be addressing the NYU caregiver intervention for us here today. And finally, our third speaker will be Dr. Lisa Easom. She's the executive director of the Rosalind Carter Institute for Caregiving and the Pope Eminent Scholar at Georgia Southwestern State University. And she's going to be talking about a couple of things here. The Georgia Care Consultation, which is a translation of the Cleveland Managed Care Program, and then Georgia Reach, which is a translation of Reach 2. So I think we have some pretty exciting presentations here. Let me just kind of briefly review so you can think about these in advance, the kinds of questions we're going to ask during the facilitated discussion following their presentations. There's going to be a question dealing with the hurdles they needed to overcome related to translation and implementation of their interventions. We're going to ask them to describe, again, those participant processes of recruitment and retention and enrollment related to bringing the intervention to scale at the community level. There'll be a discussion about the challenges of successful sustainability in the community, including, if it's applicable, the ability to get third-party reimbursements. And then finally, their top 3 recommendations for federal, state, and private resources and to promote translations in the community. So with that, I will turn it over to Laura Gitlin.